Good morning. This is a case of full mouth rehabilitation, plan for implant supported FPD in lower arch and implant supported overdenture in upper arch. These were the.
So you're going in for a full mouth rehabilitation with implants, which you have planned as an overdenture in the upper arch and full lower arch to be supported by implants, which is going to harbor an FPD. You've got an option of implant supported FPD here, or you can go in for much lighter weight, less stress bearing hybrid dentures also. So you've got an option of hybrid denture or an implant supported FPD. And it's all dependent upon the implants which are going to give it support to the FPD and probably to the bone that's going to support the implant. Here when you see the dimensions of the implants placed, you have a diameter of 4.25 for 3.75, 3.3, 3.75, and another 3.75. They're all good diameter implants. So naturally, we expect that much amount of bone also would have been present in this area, which is not always a possibility. So here you have implants with good diameter, which shows there was sufficient width of bone present there. Now, when you see the length of the implants placed, the distalmost one, the one on the one in the fourth quadrant, that is replacing that 7 tooth, 7 number 2, that is second molar tooth, you got a length of only 8. But when you see the premolar region, you've got a length of 15, which is quite a long one. Then in lateral incisor area, you've got another 15. Then the other side premolar, you've got 15. And then the distalmost on the third quadrant, again, you've got 8 mm. So the distalmost areas have got lesser, longer implants, but quite good in diameter. As we always know, implant supported FPD should have maximum number of implants. Second choice is maximum diameter implant. And the third choice is always a longer implant. But when you consider all the 5 implants down there, they are all quite good in their dimensions. So that simply shows you can try in for an implant supported FPD or a hybrid denture, whatever implant supported process of your choice, considering the size of the implants placed. Now we need to know whether they are all integrated well or not. The only possibility of knowing it is through CBCT. So all the areas should be again imaged with CBCT, and the integrity of its osseo integrated level, whether it is completely osseo integrated from its platform to the base in all aspects, which can be only assessed through CBCT. So if you take a CBCT of these 5 sites, you should be having a report saying it is all fine, well integrated, without any space in between the implant and the bone surface, with sufficient density throughout the implant bone interface. That's what you expect to get in a CBCT report. And if the CBCT report says all 5 are fine, well integrated, you can go ahead with it. In implant supported FPD is the best choice, right? And if they say some of these implants are having some lesser amount of osseo integration, or some amount are having bone loss in some particular areas, your design will have to change accordingly. And here, the whole support is to be borne by the implants alone when you're going for implant supported FPD. If you're going in for a hybrid denture, then there is a chance that the hybrid denture has got an implant as well as tissue supporting support also. some amount of tissue also is there to support the implants. But here, as we see, it's all well integrated without any bone loss. Your choice is going to be implant supported FPD without any flange or additional thing around it, which is very well in par with the maintenance phase which you need to be doing thereafter, which is very important in an implant long run. In an implant life, maintenance is very important, and maintenance can be best achieved through implant supported FPD design rather than anything that has got an additional flange onto that, which will make a maintenance difficult. So few things that we need to be sure about is, are you going to place screw supported processes or a cemented processes here? Yeah, it's always screw supported, screw retained process that is to be given. Cemented is always a compromise. Screw supported implant is the thing what you should be planning. So you have got a lateral incisor coming in your way, which is not a very welcoming thing when you consider a screw supported, a screw retained processes, because that screw hole might come on the labial side. Whereas the other two teeth are not in the canine region, it is still away. It's in the premolar side, which you can have a screw facing the labial side as well, which you can mask it with composite restoration. The screw hole can be covered or restored with a composite restoration. So that is possible. But a lateral incisor is not going to give you that permission. Lateral incisor having a screw there in front, maybe not much as much as it is in the upper anterior region, but definitely that's going to have its own aesthetic issues related to it. So screw retained one. Another thing, anything else that you need to be sure about? All your occlusal load should be directed towards the place of implant, not in between or as a cantilever beyond it. So all the forces should be directed towards the implant. So whichever area is in coming in contact with the opposite arch should be in the area of implant to the maximum, lesser to the areas of in between region. So screw retained is one objective. So whatever you're going to plan here has to be screw retained, finally landing it up in screw retained. Second thing is your occlusion, which is very important. And another thing is, that's something that you need to be considered about is the jaw relation. The relationship of this entire thing to the TMJ. If any of these things are not in harmony, then your implant is going to fail. Whatever good your implant is integrated, now you're going to destroy the whole thing through a prosthesis appearance. So it's always a prosthetic driven planning that you do. So when an implant is planned, that should be always planned with the final look of processes in the patient's mouth, retrospectively to the placement of implant. So it should not be something like you have placed an implant in whichever possible areas of the best bone available area, and finally you'll end up in a condition where you cannot load it into the aesthetic level what the patient demands. Then that implant should be considered as a failure. So considering all those things, we have got things placed here. Things are all well integrated. They were all, few of them were immediate implants. Most of them were immediate implants, yeah. So we have waited for how many months? So that many months are over. So you have waited for more than 4 months time. So they are all shown to be well integrated. Now comes the most difficult part of implant processes. That is the impression recording part. When I say it is most difficult, it's because we've been taught about placement of implant by a lot of people in a lot of places and in various platforms. But impression making and the design of processes and all those things are not much taught to everybody in general. So we have got different methods of doing it. The conventional, the traditional way of doing it with the impression copings, special trays, and the rubber base impression material, which you need to have a certain amount of the skill. We have hand skill as well as some designing part also is always involved in it. But if you understood the fundamentals of how the impression has to be recorded, then rest of the things falls in place. So you've got an open tray technique and a closed tray technique of impression recording. When you consider implant level impressions here. So you're going to have an implant level impression. Implant level impression means the implant is there in the patient's mouth. You are going to make an impression which will finally make a model which will be having implant exactly in the same position as it is in the patient's mouth. So indirectly, what I mean to say is you're going to make an impression of the position of the implants in the patient's mouth. Your objective of this impression making is to create a model which will exactly replicate the position of implants in the patient's mouth. So you're not going to take an impression of the implant. You're not going to make an impression of anything of its suprastructure. All you're planning to do is do certain things which will finally give you a model which will be exact replica of patient's mouth with implants. So implant level impression is planned here. So you have got an implant in patient's mouth. Now you'll be having a series of steps wherein the patient has come with a certain condition. You open it up, implant is retrieved. Then you have placed a healing abutment over it. Something very similar to an ear piercing. You've done an ear piercing and you place an earring in it, which the tissue won't get healed again with closing the hole. So you need to have something which once you have retrieved the implant area, you need to place something in that position so that the tissue will not get closed back again. So that's going to be permanently there till you place the final one. In between, you will remove it and do whatever procedure you want, but you will still be placing back the same healing abutment there. So the area is to be now opened, the implant area is to be opened and healing abutment is to be placed. Then during the process of impression making, you will remove that and place something else, take an impression, then remove it and place back the healing abutment, and the patient will be always, all the time from hereafter, either with the final thing or with the healing abutment in place. Then you have something called impression coping, which in other words should be understood as a duplicate abutment, something like a duplicate abutment. So it's not exactly the kind of abutment that's going to be the tooth in final form. But this is something which will be exactly doing the purpose of the abutment, but will be having certain design on it to provide a grip to the impression material. That's your impression copings. So they are all impression copings. So impression copings are things that you're going to place onto this implant and screw it down there. And the impression is going to be fixing these copings to the impression material. That you'll get to know about it as you go through each of these steps. So the idea is you place the impression copings exactly onto the implant and screw it. Then remove the copings along with the impression. So that finally you will get an impression inside which all the copings will be in the position of the corresponding implants. So that when you place a duplicate implant onto it and pour a cast, you will be having a cast with implants placed in it, duplicate implants, which are otherwise called as analogs. Implant analogs. Implant analogs are duplicate implants. So you'll have analogs inside the cast corresponding to the copings inside the impression. Then you remove the impression from the model, you get exactly the implants in position, the duplicate implants in position inside the cast corresponding to the copings which you have right now recorded. Regarding the basics, you understood about it. Now you'll see the steps in which how you make an impression. Finally, pouring the impression, all those things are done in the laboratory. So that part again, we'll have a discussion further. What are the steps to be taken, or rather, what are the steps they do in the lab to make it a model? We'll have it in another presentation. So we right now we'll have a complete series of steps of how to record a full mouth lower jaw, implant level conventional technique of impression making. Okay. See.
4 months after implant placement, electrocautery assisted implant exposure was done in relation to people with implantation.
So what you have there is right now the sites of implant. You have retrieved it with electrocautery. Okay. You use laser otherwise or surgical technique to retrieve the implants. So what you see there are all cover screws, right? The one on my left is all cover screw in place. I think on the right right is a picture where cover screws are removed. Okay. Then you have placed healing abutments in place. So that those healing abutments are placed in such a manner that now those tissues are not going to cover up that area once again. So that will be kept away. Moreover, a gingival sulcus. Here you can call it a mucosal sulcus. Peri-implant mucosal sulcus will be formed exactly in the shape of the healing abutments. Okay. Then
after healing period of 2 weeks, primary parts will be special period.
So this is the process of special tray making. A simple technique what you can do in within your constraints of clinic itself. So you made a special tray which has got 3 holes onto it, and then one long area, one gap in the tray, which indicates that area needs a splinting. So this can be otherwise also designed with all the implants splint together. So special trays can be made in such a way that you splinted all the areas together, splinted the impression copings which you are going to place. Not this one. So once you place all the impression copings and then splint all the things together, then this tray would have had a single groove on its top. Here, since you have bit confident about having an impression or the 3, 4, 4, 4, which are they? 4, 2 and 4, 4 region, you want it to be splinted. Rest of the things you're confident about getting it in that single hole itself. So it's designs of special tray varies according to the position of the implant and the level of confidence that that's going to give you. Then healing abutments are removed and the copings are placed in position. So these are all copings in position with the one, what you see down there with the grip are the real copings. And the one you seeing projecting as hole, they are all long screws. So if you see here, it has got a long screw as well as a coping. So the real coping is the one what you see down there, and what you see projecting it as cylinder on from inside of it are long screws that has attached the copings onto the implant. So now all these things are placed and an X-ray is being taken to confirm its tightness. All the coping should be positioned well into the implant and long screws are attached to it, tightened so that the copings will be fitting exactly precisely into the implant. And if you notice, this is not the complete thing what you see there is not your coping. It's coping along with long screws. Okay, then. So here you can have a better view of it. Half of it is your coping part and the one projecting out is long screw. So long screws are seen projecting from inside the copings. and you've splinted the possible one, the 3, 2, and okay, 4, 2, and 4, 4 region. You've splinted it together. First thing you've done it with a metal connector. Then you've applied, you've placed composite over it and splitting those two implants together, because I think the placement has got some angulation here. So you're worried about one of those things getting distorted when you remove the impression material fixed onto the coping here. So you have splinted it together. So two of those implants are splinted together, and the other ones are all having a gap on top of it, a hole on top of its tray. So these are the splinted ones. Then, so now you have placed back the tray in position and you have checked the tray. So with that tray, what you see is two of those implants being splinted together, going very well into the tray with the hole. Then you have 3 separate holes there. The entire thing will be now used as a tray to hold the rubber base impression material. And here you can see an impression being taken. And that's the final impression that you see out there. So that final impression, what you see there, has got 5 implant copings inside it. So what you have done is, with the special tray, you have loaded the impression material, and the special tray is being brought and placed over the impression copings, exactly like the way you see in the first picture. So to get the proper impression, so the proper impression of the sulcus area, you use some amount of soft body also. So the soft body is being pushed into the sulcus area of all the impression copings, and rest of the areas are now tightened or fixed with your rubber base hard body putty material. So now you have placed it. The second picture, what you see is the entire thing in patient's mouth. The rubber base inside the patient's mouth, and you can see the rubber base, the hard body, the putty material projecting out, and all the 5 long screws are seen projecting outside the tray. Once the impression material is set, you will remove all the 5 long screws from it. So naturally, the impression copings are still in the implant platform area, that is the external hex jointing with the internal hex. It will be still in the same position. Only thing is, you have removed the long screw so that the copings will become loose now, or rather it won't be fixed now anymore. It will be only fixed to the implant area. The rest of the portion is inside the rubber base now. So the long screws are removed from the second picture. That is what you see in the third one on top. So all the long screws from the copings are removed, and the impression is removed from the patient's mouth, and you get a final impression. So if you see the final impression closely, if you see that, you can see it has got impression copings inside it, exactly corresponding to the place of implant in the patient's mouth. This is what all you need to do. Then you're going to send the entire thing to the lab with the long screw and your analogs. Analogs are to be sent to the lab. So they'll be doing a reverse procedure of placing the long screw back into the impression from top and fixing the analog to the impression copings, and then pour the cast. So you have got now the impressions of the position of the implant inside the impression. Now corresponding to that, you need to have duplicate implants placed in the cast. So finally, you will get a cast or the model which has got implants in it exactly corresponding to the patients. So this is the conventional way of doing it. Now the entire thing has been simplified without a tray, without any of these components, into digital level. So that part also. Now we'll compare this conventional one with the much easier digital one after this. Okay. And now we'll have a look at how intraoral scanning is being done. That is a digital impression being taken. So, case.
Just the shining 3D scanning unit that is used for taking the digital impressions. This is the scanning tips which are used for taking.
They got multiple tips for scanning some special areas. You need a smaller tip to have an access to the inaccessible areas. Similarly, so they are basically the tips of the scanning.
Now, this is the case. Here we have removed the healing abutment.
So the healing abutments were there in place. Of course, this is not the same case what we saw in the conventional one. This is another case. So it's similar one, the lower one itself. It has got 5 implants in place. So all the healing abutments are being removed. On the right, on my left, you can see the healing abutments being there. The right one shows all the healing abutments being removed, and they are the impression retrieved sides.
Now, this is the scanning body.
Yeah, you need something called a scan body. So these are the things that's going to act as the abutments, the normal abutments as being replaced by scan bodies here. So this is basically a abutment itself. So we can call it a scan body, which is something very similar to the kind of impression copings. So it's impression copings for digital purpose. Then
Scan body placed.
so you need to have 5 scan bodies for this case, but in an economical way, you can have 2 or 3 in your clinic, which probably you can use it for the another side. Once the one side is already scanned, you can use the same thing on the other side and take complete impression. So we do have 3 scan bodies here, but have around 5 implants to be done. So what we do is we'll fix up these 3 scan bodies in one area, get the thing scanned, and then remove and place the same scan body to the other side and scan that area. This is possible. If we have all the 5 scan bodies together, we have done it together also.
We have taken the radiograph.
Yeah. Scan bodies have to be fixed in place, and the radiograph has to be confirmed to know whether it is seated properly in the place. You can see a video of intraoral scanning being done. That's the way they prepare for the scanning. You've got 2 windows here, one showing how what's happening in the mouth, the other one is how is it recorded in the computer. So instead of making an impression, this is scanning the position of the scan body. The scan bodies are different for each system. So this is GMI Frontier system what we use. So this is the final the scan print, this scan, how this is going to be sent to the lab. So the same thing what we saw in the conventional one, you can see the entire thing what has been taken out as a rubber-based impression material with the coping inside. The same thing as being scanned, and what we have got here is something that we can directly send to the lab and get it confirmed with the lab technician whether it is proper or not. In case something else has to be done at this point of time, the entire thing can be repeated or corrected, added, modified. All those things can be done at this point of time and then fix it. So this thing was communicated with the technician. He said, okay, fine. And the impression is being already sent to the lab. Finished. Yeah. So that's the approval got from the lab technician, and we have loaded it now. Now, as you have noticed here, most of the implants were not in a very favorable position to have a single plane. So we had an objective of having a screw retained processes for this. So whether that's going to be a reality now, the technician has to decide. But as far as we understand, this cannot be in the single plane, having this implants having its direction in multiple planes. So the suggestion for this case would be a few angulated abutments with a cemented restoration, or the classic multi-unit abutments. So every system gives you multi-unit abutments to have some sort of adjustments that can be done with these kind of implants being placed, and we can sort out the kind of disparities between the angulations. So now the choice was definitely going in for angulated abutment in either cases, and then cemented restoration or multi-unit abutments. So regarding the follow-up of these things, we'll have another class, as well as multi-unit abutments. We'll discuss about it later.